You're listening to the RN Mentor, a podcast designed to document and bring you the work and experience of some of the most influential nurses in our profession. We will be sitting down and having a discussion with the leaders of today's nursing world as they share their work, how they navigate their nursing path, and their views on the future of the profession. My name is Ali Tayeb. I am a registered nurse, United States Navy veteran, a Jonas Veterans Healthcare Scholar, and your host for the RN Mentor. Hello and welcome to another episode of the RN Mentor podcast. I am being joined today by Dr. David Keepnews. Dr. Keepnews is currently Executive Director of the Washington State Nurses Association, a professional association and labor union. He has devoted the past 3 decades of his professional career to advancing the nursing profession as a policy analyst, advocate, educator, and educational administrator. He has backgrounds in nursing, public health, law, and health policy. He has served as policy director for the American Nurses Association and served in leadership positions in state and national nursing organizations, including the American Academy of Nursing, where he served as a board member for 6 years. Dr. Keepnews is a fellow of the American Academy of Nursing, the New York Academy of Medicine, and the Academy of Nursing Education. He is board certified as a nurse executive, advanced by the American Nurses Credentialing Center, and is an alumnus of the Robert Wood Johnson Foundation Executive Nurse Fellows Program. He is currently a board member of the Washington Center for Nursing and sits on the board of Children and Adults with Attention Deficit/Hyperactivity Disorder. Welcome to the show, Dr. Keepnews.
Thank you. I'm glad to be here.
I know you're super busy, so I appreciate you spending a few minutes with me today. I'm going to start with asking you, how did you get started in the world of nursing?
Many years ago. When I graduated high school, I had no idea what I wanted to do when I grew up, even though at that point I thought I was grown up. And sort of started off in college actually as a Latin American studies major, even though I had never been to Latin America, but I was interested in Latin America and liked to practice my Spanish, but sort of realized that wasn't necessarily where I wanted to go in terms of my academic focus or my sort of professional pursuit, and just sort of wandered in the desert, so to speak, and then decided, okay, if I don't know what I want to do, let me take some time off and not waste time. And I always like learning, but sort of let me find my focus before I do this. And by that time I was living in San Francisco. I went to work initially in medical records and then as a unit clerk in a hospital in San Francisco. I knew I was interested in healthcare and in working with people and helping people, didn't know what my focus would be. And while working as a unit clerk, I was able to observe what nurses were doing, get to know a lot of nurses. And I was so impressed at that point by what nurses did for patients and how they did it. I happened to work in various units because I was afloat, and was really impressed by the level of commitment and compassion, and also I think the diplomatic skills in dealing with family members, and especially in dealing with physicians and other professionals, and just the level of independence and of being able to think for themselves and advocate for the patient. And, that advocacy, as I saw it, took different forms. I mean, there were times when, you really argue and really get into a conflict, whether it was with, nursing supervisor over staffing issues, or with a physician that was insisting on something that would be harmful, but often it would be in more subtle ways of sort of alerting the physician to an error that she or he made without embarrassing them and without sort of creating friction there. And I was really amazed at that combination of technical skills, of scientific knowledge, and just that innate understanding of people and sort of how to work effectively with difficult people, and just sort of how to read the room, so to speak. And it really presented itself as just being so effective for patients, really caring and really knowing so much. And I just thought, this looks great. If I can be like that, that's what I want to do. And so I applied to nursing school and went and continued actually working per diem as a unit clerk for most of that time, which was a great combination because most of the nurses by then knew me, so they were really supportive. They also made sure that I was warned about some of the things that I'd encounter in nursing, but also really eager to teach me, to sort of just to keep me alert as to things that were going on. So anyway, that's a very long answer, but that's how I first got into nursing.
That's awesome. Now, did you go to, what kind of program did you go into? Was it a 4-year program, or?
It was a traditional 4-year program. During my previous time in school, I hadn't completed a degree, and in those days we didn't have advanced accelerated rather
Right.
second degree programs. So it was a 4-year program. I had to start from the beginning as a freshman at my advanced age at that time of 23. It's actually funny because at that time faculty would sort of identify me as an adult learner, and I was one of the older students in my class at age 23. It seemed to people who are coming into nursing now, that probably seems very odd, because I now see a wide range of ages and experience of people coming into nursing. But in those days and at that particular school, it was mainly a traditional group of people starting right after high school, primarily female. I think I was out of a class. It was a very large class of maybe 150 people, and I think there were 5 men. So things have changed a lot, but yeah, so I did that. I was able to take a lighter load later on because a lot of the courses I'd taken before were electives. But yeah, I did a 4-year program.
That's great. I think I want to say by the time I got into nursing program, I think I want to say I was like 31, because I had been in the service before I got out and went back to school. And it's a different animal going to school as an older person. I don't want to say I was like as somebody who wasn't the traditional straight out of high school. So it's different, and you're even treated a little bit different, which is strange. That's great. Now, what was your first experience as going into the nursing workforce? Like, how did you start out your professional career?
Well, I started out in psychiatric nursing. The common wisdom that I heard from most people was, first of all, as we were doing our different rotations, I loved psych. I loved peds also. Med-surg was okay, but not
your cup of tea.
It wasn't what drew me, and that's criticism of it. But so I really felt, this sounds strange, I felt I belonged in psych. That could be misinterpreted or not. But and the common wisdom was, no, you have to go right into med-surg. You need the foundation of those skills. You need to do that. And people would tell you differently, at least 6 months, at least a year, at least 2 years. And I really struggled with that. And, on the one hand, didn't want to do something that was going to harm me in terms of learning and getting the experience I needed. But on the other hand, didn't want to take a traditional route just because it was the traditional route, and sort of decided that I would go right into the specialty in which I really wanted to work. And maybe in some ways it was because everybody was telling me I needed to do something like the way they did it, that made me want to do something different. But anyway,
Yeah.
I started off in psych at one of the locked inpatient units at San Francisco General Hospital, county hospital there, and I really loved it. And I really liked work. It's funny. Before I graduated, I worked through a registry through an agency as a nursing assistant, and was assigned to psych units in different hospitals. And I remember speaking with people at a psych unit at one private hospital, which shall go nameless, but they were sort of showing me around, and then they said, well, we only have one seclusion room and we don't have restraints. And I said, well, what do you do with patients that are really, really aggressive or really, and she goes, oh, well, we send them to San Francisco General Hospital. we don't work with it. And I had done my psych rotation there, and I thought, okay, that's where I want to work. I want to work in the place that takes the patients that nobody else will take. And that was definitely San Francisco General. I did that, and then worked at Community Mental Health Center, what was then Mission Mental Health in San Francisco, in their acute day treatment program for a little while. So anyway, that was my start, and did psych, community mental health. Later worked in a substance abuse clinic, and then worked many years, especially when I went back to school and was working per diem in psych emergency. So I worked in psych emergency first in New York at Bellevue Hospital, and then at San Francisco General for several years. And I enjoyed that.
That's great. That's great. You mentioned something that you didn't want to do what everybody else was sort of telling you. And I was sort of the same way, because it's so funny of how many faculty we have within the world of nursing that are sort of, I want to say, feel that traditional route of you need to have med surg before you do anything else. And I drank that Kool-Aid for a while. And even though that wasn't the route that I took, but I used to preach that to other people. And then after I started questioning myself, I'm like, why am I preaching that? Because there's so many other opportunities, and so many people are successful going straight into a specialty.
Yeah. I mean,
So,
there are reasons to do it. It's not
right.
totally irrational advice. I mean,
Right.
I think there are reasons to do it, but I think it depends on sort of if people if newly graduating nurses have identified a passion for a specific area. I mean, when I was teaching in nursing, and then when I was a dean for a while, and you would talk to students who just knew they wanted to work in OB. They wanted to work in L&D. I mean, this was what they loved and what they wanted to do, and they were tortured by the idea of spending 2 years in med surg, not because obviously there's a need for med surg, but in their hearts were telling them, and it's like, why, especially when there are shortages all over, like why do that? But on the other hand, certainly I think if somebody isn't sure, it makes good sense. And I think there are sort of foundational skills that you can get that certainly are transferable, and sort of learning just assessment, organization, and so I think it depends. So I don't think it's it's off the wall to recommend it, but not as sort of a religious tenet of,
Right.
that, thou shalt only start off med surge.
I agree. I mean, for me, I think the biggest push, because med surg is its own specialty. Like
Yes.
I've worked emergency room, and I've attempted to work med surg, and it's a completely different skill set. So it is its own specialty, and I think what the reason I kind of moved away from preaching sort of everybody should do med surg first is because there aren't many programs in place that make it easy for you to transfer into a specialty once you've gone into a med surg unit, right? Like if I want to go critical care, it's difficult to make that transition with a solid program to transition you into critical care. And I think that's where my hangup is right now, is I wish there was better programs in place within the institution that helped you transfer into specialty areas if you decided to do that. Or
Yes.
so yeah, I agree. But again, med surg is its own specialty, and I'm very humbled by the work that med surg nurses do.
Absolutely.
Yeah.
Absolutely.
So how did you what was your next step after you did your psych rotation? Because I know you eventually got into law and other areas. How did you make that?
So I worked in psych and mental health for a while, and it's interesting. While I was working in community mental health in San Francisco, now I'd always been interested in politics and social issues. I hadn't necessarily considered yet how that might develop into sort of a specialty interest of mine in terms of nursing and healthcare. But there was a change in the law in California, and we're talking 30 something years ago, no, close to 40 years ago, but for the state Medicaid program, or Medi-Cal in California, where at one time it would be anybody that didn't have insurance and needed medical care would automatically be enrolled into Medi-Cal. So, and then there was a change. This is for the so-called medically indigent adult program, where those individuals who had no insurance and didn't otherwise qualify for the sort of traditional standards for Medi-Cal could only be hospitalized at their county facility. So literally overnight, because I think that went into effect on I think it was July 1st of that year, if that was the start of the fiscal year, where I worked in an acute day treatment program. If we had a patient who needed to be hospitalized, because it was really more like either a transitional program sort of for people who didn't need a hospitalization but needed some structured program, but it was also an alternative to hospitalization for people who might be acute but not in need of hospitalization. And sometimes it turns out that those folks did. I mean, you sort of try them on this outpatient basis, and so it was not unheard of that we would have to send patients to be evaluated at psych emergency, and then if they needed to be hospitalized, basically any hospital that had a bed available could take patients from the county hospital psych emergency. So with this change in the law, the patients, and not just our patients, but any patients who showed up to psych emergency and needed hospitalization, if they didn't have insurance, including if they didn't have current Medicaid or Medi-Cal, they could only be hospitalized at that hospital. Now, at the time, I think there were 4 inpatient units, so there were a lot of beds, but the beds would fill up, and then those patients would spend days and sometimes several days waiting around in a relatively small psych emergency room. And so sort of that abrupt change in this law that I think nobody that I knew they might have been vaguely aware of that change or probably not, but to see the immediate effect on our patients and other patients, to go from where if you needed a hospital bed, you might have a wait of a few hours until the bed opened up somewhere, but to where people were staying in psych emergency for days and being managed. I mean, it's not exactly a therapeutic milieu. I mean, just that sea change literally overnight. And here I am, working as a nurse, and I thought fairly aware of political issues. And as I said, no one that I knew and worked with had any idea this change was coming. And sort of seeing how even what was seen as sort of just most people just think, oh, that's one of those sort of complex, bureaucratic changes. And it really got me to thinking about that connection between policy and patient care and public health. And again, it wasn't that I'd never thought about sort of social issues and policy, but I didn't know much about it. And it really started me focused on understanding that process in terms of legislation, but also regulation, it's sort of the implementation and how those things are carried out. And then, of course, led to an interest in how we as nurses and other professionals, first of all, need to have some awareness of that, not see it as the domain just of experts, but that we need to have some basic understanding, both to be alert to those changes, but also how we help to shape those changes. If we're going to be effective advocates for our patients and for ourselves, we need to know what's going on in state legislatures, in Congress, need to make ourselves heard, and then be ready to advocate. And so that got me interested in that. And soon after that, or relatively soon after that, I decided at that point to go to law school, because that was the route that I was aware of in terms of understanding laws, policies, the legal system, and the impact on patient care. So that was sort of my entree into that. After law school, I worked for about a year for the regional office in San Francisco of the U.S. Department of Health and Human Services in their regional attorney's office. And then the California Nurses Association, which at that time was still affiliated with ANA as a professional association. I literally saw an ad in the paper for they were recruiting for a staff member, a staff person to work in their lobbying office, and focusing on relationships with government agencies, so sort of with regulatory policy. And it's funny, I looked at doing that, and because I was living in San Francisco, the job was in Sacramento, and most people in San Francisco have a certain attitude about Sacramento, sort of like, where is it? And I sort of debated back and forth about it. And what's funny is one of my good friends in law school said, well, if you don't apply for that job in Sacramento, I'm never going to talk to you again. And I said, well, really? That's like, I mean, he didn't literally mean it, but he said, don't you remember on like the first day of law school when we met, and you said that I said, when people said, well, what do you plan to do when you finish? And I said, well, I'm not sure if I'm really going to, spend my career practicing as a lawyer. And they said, well, like, what else would you do? And I apparently said, because he said that I said, I don't know, maybe I'll go work as a lobbyist for the Nurses Association. So he said this was, so I said, okay, if I said it, then anyway, so that was sort of my entree into into health policy for nursing. So it was really working and advocating before the different health agencies, the Board of Registered Nursing, other government agencies that had an impact on health and on nursing.
That's great. It's not a path that too many. I know. Actually, I know. I want to say I know like 5 or 6 people that have taken the path you've taken with the law school, but it's not a path too many nurses take. And it's commendable because it's like sort of a dedication to understanding. Because I work in the veteran community quite a bit, and some of the stuff I read, I have to reach out to a friend of mine who works in the same community, but he's got a law background. And I'm like, what does this mean? Please explain to me what they're saying here.
Well, I mean, a couple of things real quickly. One is, I think that route of being a nurse and an attorney, it's certainly becoming more common. I mean, when I started law school, I think, I don't know, I think there were just a relative handful. There was, and there still is, the American Association of Nurse Attorneys, which has continued to grow and I think attract more people. So it's less uncommon than it used to be. But the other thing is, the example that you gave of sort of having, ask an attorney friend, like, what does this mean? This is one thing that I've really been devoted to. I mean, that sort of the ability to translate from sort of bureaucraties into English or whatever
Right.
language someone might prefer. And I think it's a really important skill, but one of the things I've always say, whatever role I've been in, this included, when I was teaching and when I would teach health policy, is like, don't be intimidated by, it's just like we speak in code sometimes because, I remember at one point talking to my brother about my late father, but when he was alive and sort of having some difficulties, and my brother was visiting him, and I said, well, is he ambulatory? And my brother goes, what does that mean? You mean, is he walking? And I said, oh yeah, that's what I meant. And so, just as we sort of have our lingo, it's sort of policymakers and bureaucrats tend to have theirs. But what I also tell people is that don't be intimidated, because often, like, these rules and policies are written in a way, intentionally or not, but I think it's sort of embedded in the culture. They're written in a way that to discourage you from reading them and understanding them, because it sort of belongs to this, insider group.
Right.
So I really try to sort of demystify that, and I just think try to help make people see that these are accessible, and that, I mean, certainly it makes sense to talk to people with expertise, and if it's not clear, but I really reject the idea that understanding sort of laws, legislation, regulations, policy has to belong only to so-called experts, because I really believe in a more democratic, if you will, approach to that. And that, to me, it's part of empowerment for nurses and for others. And when I used to teach health policy in nursing school, I mean, you would see, well, back when we taught in person and you could see people's reactions, people would start off, many of them very nervous about this stuff, and at the point that they're able to really get it and sort of be able to do that translation in their heads and really understand. I mean, it's exciting to see. And to me, that applies not just with students, but now that I'm in the position that I'm in, with many members, and sort of, again, encouraging people to understand and to be interested, and to recognize that it's not as complicated as people would have you think.
Right.
And so, yeah.
I think my biggest hangup is when it starts getting into some of the, like you said, the terminology. And I'm like, what? So I always am like, is this what I think it means, or am I reading this now? So I think it's important for nurses to, and especially if you're doing advocacy work, to understand what we are supporting or advocating for, especially, and then learning some of that language. So very important. But that's not where you left your career. You went on and got your PhD, and you've been in academia. How did you maneuver through those?
Well, so when I worked for CNA, for the California Nurses Association, I was there for about 4 years. Position opened up at the American Nurses Association, actually dealing with, again, primarily with regulatory issues. And so initially I was in their government relations office, but some of them were the same issues I dealt with. Actually, one issue that sort of followed me around for much of my career was reimbursement for advanced practice nurses. And I did a lot of work on that at CNA, and then did a lot of work on that at ANA. So that was sort of my transition to ANA, and then was in a few different roles. We had the executive director at that time, Jerry Marullo, started an office of policy, because we had people doing work in policy in various ways, certainly a very able lobbying office, and many of the different departments were doing different things that touched on policy. Now, this was a really long time ago. So this was in the early and mid 90s. Initially, when I went there, that was right at the start of the Bill Clinton health reform proposal, which some of your listeners may remember, and others it may be, prehistory. But and one of the things was sort of having everybody on track, and sort of with the same understanding and the same messaging, because the policy environment was changing so quickly. So a lot of what I did was really coordinating sort of policy positions, policy initiatives, and a lot of writing, but really sort of helping to head up that sort of unified effort on policy. And I became more and more aware that really to speak authoritatively on policy, that more and more policymakers were looking at and expecting an evidence base to what was being advocated, and to be able to answer questions about it. So I think research was becoming more and more an element of policy. It was not an area that I really had been learning about. The other thing was, after, at that point, about 8 years of advocating for nursing, I felt like I developed a lot of expertise in nursing issues related to policy, but that was somewhat narrow. And I wanted a broader understanding of health policy issues. My feeling was, even if I went right back to advocating for nursing, I wanted a broader base of knowledge. So I went to the PhD program at the Heller Graduate School at Brandeis University, which had the degree was in social policy, but it included a health policy concentration. It had and continues to have a really strong reputation in that area. I was lucky enough to get get funding, fellowship from AHRQ, and so at the federal government, and so did that, and so did my PhD there, and from there I began sort of my teaching career, my academic career, but at the same time, sort of, although I was no longer on staff with the nursing organizations, remained active, and as with a few other academics, sort of with a policy focus or with other focuses, sometimes the teaching environment or the university environment sometimes is also a good home from which to to be active in nursing organizations, and it's not that the two aren't related, but so that kept me current, if you will, in terms of policy, and I really enjoyed working with students, especially focusing on policy, but also just having a chance to work with people entering the profession, and also with people who have been in the profession and are looking at advancing their roles. And even though I'm not a clinician, certainly not an advanced clinician, my feeling and strong belief, and I know I'm not alone in this, is that nurses, and especially, well, I don't want to say especially, but definitely including nurses going into advanced roles, really need a grasp of policy, whether they believe that or not at the point that they're students. So I as I said, I got accustomed to sort of starting off a semester with a lot of skeptical students who were in the class just because they had to, and it was sort of part of my job was to make them be interested, make them understand why it was relevant, and I think that's what I particularly loved. And I would generally be really enthusiastic about it, and people would sort of see, either I was just crazy, or maybe there really was something interesting, or maybe both were true. But I really enjoyed that process of seeing people who would start off thinking, this has nothing to do with me, I'm just being forced to take this strange class, and then by the end, where people really got it and really felt that they had at least the beginning tools to really understand policy, and then to really help fill their roles as advocates, not just at the bedside or the clinic, but addressing the sort of the broader issues.
Yeah, I agree. Policy just impacts so much of what we do, but we don't necessarily call it out. I throw in a little bit of policy in my undergraduate leadership courses, and so many of my students are like, I never knew, like, my work was impacted by this, or new laws or legislation that comes out, and how they're impacting the workforce, our patients, our patient populations. They're just because they're not called out anywhere else, and
Right.
if you're not looking for it, you're not going to find it.
And also recognizing that many, certainly not all, but many of the problems that nurses encounter in practice, often the solutions come through policy initiatives. And
Right.
we've seen this over the years in addressing mandatory overtime, or I remember around efforts for safer needles, and certainly around staffing, which I think is far and away the biggest issue affecting nursing practice right now. And certainly we have the example of California in terms of staffing ratios. And here in Washington State, Washington State Nurses Association, the organization where I'm executive director, has been working in coalition with two other healthcare unions to spearhead support for legislation here that would enact safe staffing standards. So would put that into law, and just think we're, even though I know some people have questions about that, should government be setting those standards? I think we're at a point now where nurses are nurses are so concerned about sort of the state of patient care, about growing patient loads. And, it's interesting because some people will say, oh, well, this is, people are burning out because of COVID. And that's not untrue, but it doesn't really capture the full picture. We've seen over the course of years in many hospitals sort of a systematic understaffing, and basically set up the situation so that with this pandemic, sort of you just don't have the reserves to lean on because staffing has been so thin. And then now with the Omicron variant and so many people contracting and then being out sick. And so the solution can't just be we're gonna double your patient loads, or we're gonna give you 3 or 4 patients in ICU. Or one thing I probably should have known, but really just recently became aware of, and I'm sure it's true not just in Washington State, but a real abuse of call time, where I mean, I was used to it just for units like the OR or some procedural units where it's unpredictable and you may need people to come in. But now in many instances, using call time basically as a substitute for staffing, and just but I mean, basically, even though it's a difficult issue because they're certainly hospitals don't like the idea of mandated standards, but we just think it's come to that. Now, we do already have a law in this state, as a few other states do, of hospitals need to have staffing committees that are half 50% RNs, 50% management, to sort of come up with staffing plans for each unit and each shift. One of the problems is that there are so many loopholes in that law that, including a sort of an exception for emergency situations or emergency circumstances, which many hospitals now have said, well, the pandemic is an emergency. And it's like, well, yes, and maybe for the first few months you needed to sort of, make some adjustments, but 2 years into it, it's a little difficult. But so we're looking at strengthening that. But, if you've got standards in place and, minimum standards, and you've got a mechanism in place like these staffing committees to adjust those upwardly, if based on patient acuity, based on any number of things, I think that can work well. And so it's been interesting to see. I mean, we're just at the start of our legislative session, but so far that's gotten a fairly good reception. We'll see. We're hoping for success on that. But anyway, my point, other than sort of talking about this bill that we're excited about, is that I think that's an example of where problems that are being encountered in practice that can't be resolved on a hospital by hospital or whatever the setting might be basis, right, need broader solutions, and that's where sort of policy and legislation enter into it.
Yeah, that's a great point. I feel a little bit vindicated. Actually, I was on the other side of the mic earlier this morning, and I was actually talking about some of the same things you brought up now with staffing issues and how the pandemic has exponentially exacerbated that whole staffing concept. And now that we're so spread thin that you don't have anywhere to go, and it's actually causing a bit of inequities depending if you can afford to pay the travel nursing rates now, whether you can't, and people leaving those community settings to go to the higher paying travel nurse positions, which is, I'm sure, is impacting many community smaller hospitals that can't afford $7,000 to $10,000 a week for travel nursing. So definitely an issue. And one of the things I want to say we sort of saw in California with the staffing ratios is some of the resources went away when when the ratios kind of came in place, where LVNs were taken off the units, CNAs were taken off the units. We saw a decrease where at one of the hospitals that I know of, they used to have pharmacists on every floor, and they took all of those away and centralized and decreased those other things that were very much part of it, which made the nursing workload a little bit, almost, I want to say, heavier, because all the resources that they were dependent on all of a sudden went away. So it was sort of like okay, you got your ratios, but we're going to take these other resources away, which maybe for Washington, it should be a heads up. Make sure you include those resources as part of the planning.
And it's interesting because, and this actually took some discussion, but in working with other unions that represent not just RNs, but other healthcare workers. So there is some attention in the bill to staffing levels for some of the other staff as well. But, part of the problem there is that, if hospitals decide to take away some of those resources, is it a question of, well, they can't afford them now that they're keeping up these ratios, or is it the same reasons why many hospitals have staffed at low levels, that they are trying to, minimize expenses, and for what purpose? Is it because they're going to go bankrupt if they do this, or is it because they want to maintain a certain profit? And as you know, even the nonprofits,
it's a business.
It's called margin. The other thing I think that we see is this rapid growth in these large national nonprofit chains. And so, I don't claim to be a total expert on all of the aspects of this, but it does seem to me sort of, in the old days, there might be conflicts over things like staffing, but the decision makers were generally in the hospital. And so even though there might be conflicts, the CNO and the CEO would know staff, they'd see staff, even if they weren't, they might, go up on the floors to see what's going on. But there's a sense of you're all in the same place. And, and if you've got some of the overall decision-making on budget and finance located at some distant, corporate site, which might be, a couple thousand miles away, it's very different. And I think it's not just that hospitals run as businesses, and to some extent they need to, but I think the corporatization and sort of where individual hospitals are just, one of many, I think takes away a lot of the human element that used to be there. So.
Yeah, a lot of those. Having worked in a couple of those, like having the headquarters not be associated, where they are in a building where there's no patient care being provided, and they're dealing with a bunch of just other executives and administrators. It's a different animal. So yeah, I agree. I completely agree. Now, since you are the executive director of a union, how do you see where do you see a lot of organizations sort of have a love-hate relationship with unions, right? Like some hospitals I know for a fact are, actively pursue a path of keeping the unions out of the hospitals. Where do you find sort of the middle ground where, because I see benefits in unions. I haven't always been a fan of the unions, but over the years, I've grown to appreciate the work that they do. And where do you see sort of the middle ground where we are working more symbiotically in the systems?
Well, I mean, I'm a great believer in collaboration and in people who may have differing interests and different perspectives, at least recognizing common ground. And I think very much for us as we are a union, but also a professional association. And, I think, we just really, it's optimal when, parties can recognize, again, where they differ. But if we have mutual interests in providing good patient care, quality patient care, and a positive environment for nurses that's going to be supportive of them, that's going to respect them, and give nurses what they need to practice well and to have some work-life balance. If both sides recognize those as common interests, I think there are great possibilities to sit down and work out agreements that work for everybody. And this is something I've found with in this state with our the staffing committees and staffing plans that really depend on a collaborative process to work. They don't work if that collaboration is one-sided. I mean, it doesn't. It really takes a commitment from both parties. So I think it's a very rough environment right now, and I think that it has become more adversarial in terms of certainly unions and hospital management. That doesn't make me happy. That's not but I think we have to recognize that that's where things are right now. My hope, and it may be naive, but I don't mind being naive, is that, we are in such a state of crisis right now, and, we're hemorrhaging nurses, and, I'm glad that there are more and more people wanting to go into nursing, but I worry about what happens. I mean, I think we all know of new nurses that just decide really quickly, this isn't for me. And what I'm hoping is that that there can be some changes that recognize that if we're going to have a sustainable healthcare system, particularly in acute care hospitals, but not just, that there has to be some long-range thinking about what keeps nurses able to continue practicing and what kind of environment. I mean, one of the things I see right now is that with the crisis that we're having now is many hospitals making things harder for the nursing staff that they have, like the whole issue of abusing call time, where
Right.
for a lot of nurses, it's like, you may end up working 16, 18 hours and then having to show up the next morning, or this idea that you may get a call at any time. I mean, whether you planned on working on call or not. And, hearing that that's a major dissatisfier, and that many people encountering that are just leaving, or they're going to per diem status because per diems don't take call. But I'm just thinking, the harder it gets out there, it's like hospital leaders, and I don't want to paint with too broad a brush, because I know it's a system. And so I think we have certainly many CNOs that see the problem, but may not be in a position to solve it. But if your response to having insufficient staff on board is to just increase the workload and give people unsafe assignments and burn people out, like, it's just feeding on itself. So I think there really is a need to take a step back and say what's needed in the long term. I don't think hospital leadership need to like all turn into nice people overnight. I mean, that would be nice, but I think they need to recognize that it's in their interest if they want to keep nurses, and also if they want to have good outcomes that also have an impact on their bottom line, that an investment in nursing pays off for them, are recognizing that. I don't think that's the dominant trend yet, but I just think if this system is going to, I mean, there's a lot of changes that need to take place in the system beyond staffing, but if it's going to survive, if it's going to be safe for patients to enter hospitals, got to start taking a different approach. And as I said, I think a lot can be worked out and set right with collaboration, but we can't be the only ones trying to collaborate.
Yeah, I agree. 100% agree. So I want to be cognizant of your time. Anything else you want to share before we end this?
I just think, I've been around a shockingly long time now, and I've seen nursing go through a lot of changes, and but I think despite the challenges, it's a profession like no other. I think the possibilities continue to be astounding. I'm so glad that so many students are still entering and seeking to enter the profession, even though everybody knows or has heard of the challenges. So to me, for those of us that are working in ways that and trying to improve the system, trying to improve and advance the profession, I think it's an even heightened responsibility. But I do think that, again, nurses recognizing the power that they do have, and both as deliverers of care, as managers of care, as educators, and effectively using their voices to shape change, that we can't just depend on other folks to do it. And I think that we can continue to set things right and to make this, I think the profession remains attractive despite the problems, but I think it will be even more so. And we can look at long range we need to make this a profession that doesn't burn people out. And I think we can do that. I think the worst thing right now is to give up hope. And we need to recognize the challenges and that we're up to them. And I think that's what I'll end with.
That's great. I greatly appreciate the work that you're doing and appreciate your voice in advocating for the profession. So thank you so much. Thank you for your time. We have been listening to Dr. David Keepnews, and we will join you again next time. Thank you very much. Have a great night. You've been listening to the RN Mentor with your host, Ali Tayeb. Please don't forget to visit www.alirtayeb.com. That's www.alirtayeb.com for podcast notes and resources. And don't forget to subscribe. Until next time, I wish you fair winds and following seas.